Now I invite Dr. Agrima Bhatia. It's rare but may be hiding there, conjunctival rhinosporio disease.
A very good afternoon, respected seniors, colleagues, and my fellow delegates. I'm Dr. Agrima, and today I'm presenting a paper titled It's Rare but May Be Hiding There, Conjunctival Rhinosporidiosis. So to introduce, rhinosporidiosis is a rare ocular infection and a chronic granulomatous disease caused by Rhinosporidium sebae, which is a protist and belongs to its independent taxonomical class known as Mesomycetozoa. Meso implying in middle of, myceto implying fungi, and zoea meaning animals. It is endemic in India and Sri Lanka. However, there are cases that have also been reported from North America and Eastern Europe. The most common presentation is a soft polypoidal pedunculated mass affecting mucous membranes of nose, pharynx, and conjunctiva. Scleral ictesia, staphyloma formation, and scleral melt have also been reported in rare cases. So to give the case details, it was a 23-year-old male resident of Kerala, known case of bronchial asthma since the last 10 years, presented with chief complaints of foreign body sensation, itching in the left eye for 2 months, associated with a sticky whitish discharge. No history of fever, skin rash, ocular trauma, or surgery. Non-specific history of something entering his eye while driving. Treatment history, which he had taken in some other hospital, included tab-lisolone 40 mg once a day, eye drops, prednisolone acetate, moxifloxacin, homatropin, nepafenac for the initial 7 days with no relief. On examination, the uncorrected visual acuity in both the eyes was 6/6. Intraocular pressure was 16 millimeters of mercury. Conjunctiva of the affected eye revealed upper tarsal conjunctival congestion and follicles on lid eversion. A 5/4 mm sized flat, pedunculated, highly congested mass with a bumpy surface attached at the inferior border of the tarsal conjunctiva, as can be seen in picture A. The grayish-white dots were displayed on the overlying surface, as can be seen in picture B. So our differential diagnosis included conjunctival papilloma, hemangioma, arteriovenous malformation, and pyogenic granuloma. We went ahead for surgical excision. So the lesion was excised. Light cautery was done at the base to arrest bleeding under local anesthesia and was sent for histopathological examination. On H&E stain, as can be seen in picture A and B, there was focal ulceration of hypertrophic lining epithelium, multiple sporangia of which few were ruptured, and lying within was the reactive mixed inflammatory cell infiltrate. The advanced stains, pus, and grockets revealed large, thick-walled, intact, and ruptured sporangia with numerous endospores within. It was then that the diagnostic surprise of rhinosporidiosis was unraveled. We continued the treatment with dapsone 50 mg twice a day. We also sought for ENT and physician opinion to rule out extraocular involvement. MRI brain and orbit was found to be within normal limits. The patient was followed up for 6 months and no recurrence was reported. Eosinophilia was noted in our case. Bronchial asthma could have been a confounder. It although settled significantly from 19 to 2%, possibly attributable to 10 days of dapsone treatment. Ocular recurrences are rare, with a rate of 1% and between 2 and 40% for conjunctiva and lacrimal sac respectively. Risk factors include a traumatized epithelium, which makes the transmission feasible when former comes in contact with contaminated water or soil. Presentation is classical with a peduncular mass associated with bleeding, pruritus, foreign body sensation. So why was the DD of pyogenic granuloma made? Because of the overlying grayish dots. Impacted foreign body could have been the other one, possibly because of epithelialization over a period of time. Hemangioma, because of the pinpoint bleeding on eye rubbing, which was also noticed in our patients 2 days before the surgery. So to look at the grid on the right, it shows all these differential diagnoses which appear to be same but are actually different, including pyogenic granuloma, impacted foreign body, hemangioma, and rhinosporidiosis, respectively. The leading question divulged the use of village swimming pool on multiple occasions during the last 6 months. Probably it was contaminated. What could be the causes of relapse? Incomplete excision of the lesion, seeding of endospores to adjacent sites during surgery, ineffective cauterization, and failure to use dapsone during the post-operative period. To decode the mechanism, it was frequent rubbing of eyes due to chronic pruritus, breach of epithelium, followed by their use of contaminated swimming pool, which invited the infection. On histopathological examination, as we have seen, multiple sporangia in various stages of degeneration, and some histological findings which in literature also cite squamous metaplasia and epithelial hyperplasia. To understand this configuration, the site of the infection may decide the configuration of lesion. Bulbar conjunctiva has a flatter and sessile lesion in view of the pressure exerted by the upper eyelid. In our case, it was arising from the tarsal conjunctiva, but probably owing to the lack of space to grow outward, it may have assumed a flatter configuration. So to conclude, rhinosporidiosis is a rare clinical entity. Diagnosis is primarily based on microscopic features, and it should definitely be borne as a differential in any case of pedunculated mass. Thank you. Thank you, sir.